that. You know?
Yeah, waiting for the podcast.
Yeah. Waiting on channel 13 to say go.
So you're originally from the Houston area?
No, I grew up in northern New Mexico.
Really?
Believe it or not, in the middle of nowhere, kind of near Taos.
Okay.
But I've been here for 25 years.
Awesome.
So,
Downtown?
yeah.
All good. All good. Okay. Hello and welcome to UTHealth House Calls presented by Mercedes-Benz dealers of Greater Houston. My name is Joe Drago and I'm the General Manager here at Mercedes-Benz of the Woodlands. Thank you for joining us tonight for the second of 7 house calls hosted throughout the Houston area covering a range of health topics. We are proud to be partnering with UTHealth to bring awareness to important health issues and the amazing work that is being done by healthcare educators, providers, and researchers at the university and its UT physicians clinics. Thanks to the partnership, I am proud to announce that Mercedes-Benz of the Woodlands will be giving 2 $5,000 scholarships to the Graduate School of Biomedical Sciences, a joint program of UTHealth and the University of Texas MD Anderson Cancer Center. Tonight's program, Innovations in Orthopedics That Are Changing the Futures of Sports Medicine, is presented by Dr. Walter Lowe, an internationally known orthopedic surgeon specializing in sports medicine. Dr. Lowe is professor and chair of the Department of Orthopedic Surgery at McGovern Medical School at UTHealth. He sees patients at UT Physicians Orthopedics at the Memorial Hermann Ironman Sports Medicine Institute, Texas Medical Center. He serves as the chief of orthopedic surgery at Memorial Hermann Texas Medical Center and Harris Health's LBJ Hospital. He is also the head team physician for the Houston Texans, Houston Rockets, University of Houston, and a number of Houston area high schools. The Q&A portion of tonight's presentation will be moderated by Karen Kaplan, medical journalist and longtime member of the UTHealth community. Thanks again for joining us tonight, and please join me in welcoming Dr. Walter Lowe.
Thanks. Okay. Thanks, Joe. Appreciate it. So it's never good to start off embarrassed when you start reading all that stuff. So I didn't really prepare a lot because I think there'll be a bunch of really good questions. And so it's kind of a fun audience for me. So first thing, the first question I always get asked is, do you really see normal people? The answer is yes. Matter of fact, I wouldn't be here if I didn't see normal people. So we'll get that one off first, or get that one out of the way first. And so that's really what makes this fun. And I will tell you one thing, there'll be a lot of these deals from some serious illnesses and those things that are certainly very important in health, but I'll have the most fun job of any of the people that are going to talk at these for sure. And then there's a bunch of guys in the audience here that work with me, for me, out here in the Woodlands, and so I definitely wanted them, Kelly Blevins here, and Kevin Coop, and David Abbasi, Joe Masterson, so they're part of my group. I want them to come just in case you guys got rowdy, to help, help protect me. But this is the group out here in the Woodlands at Ironman Sports Medicine. They're a bunch of great guys, and I think they'll be around, when we're all done today too. So when they asked me to do this, I thought it was at the Mercedes dealership at Greenway, and then they kind of pulled it on me today. So it's good to have, because I have so many patients from out here in the Woodlands. It's really kind of sobering for me to see what you guys go through to get down to the medical center. I've developed a new level of sympathy for sure. So they wanted me to talk about new innovations, and I've already had a bunch of questions about it. So I'm just going to bring up some things, and then I think we'll open it up to questions, pretty quick, because I don't want to bore you with some canned lecture for sure. So the second thing we'll get off, because I know what's coming. Everybody's ready for training camp but our running back, all right? So all the rest of them, 99.4, they're all ready for training camp. And so we can talk about those injuries if you want, but the weird thing is that's 5 days away right now. And so all of a sudden life changes again for the next 6 months. It really came pretty fast. So there's several things sports medicine wise that I think are new and exciting is probably what to say for us, but it's one of those deals that all of our new stuff always comes with a lot of hype, And I think the hype on these biologics and PRPs and bone marrow aspirates and stem cell treatments or all those things is probably a lot of the questions that I would expect a lot of you will have and a lot of the listeners on 13 will have. And so I think they're probably the most prevalent topic right now that we get questions on. And so I'll kind of define them for you, you know. And so stem cells are a really sexy word for sure right now, but you got to be careful because there's a lot of hype, there's a lot of media hype, and they're not really real yet. And so I'll go into, we all have them, we just can't tell them what to do. And we have one of the biggest stem cell researchers in the country at UT in our department, Johnny Heward. And so I asked him 4 years ago when he came, I said, you got to clear me up on the stem cell thing, because stem cells are being offered for everything. They'll grow you new meniscus, they'll grow you new cartilage cells on the end of your bone, they'll heal your hamstring, they'll cure your cancer, they're a fountain of youth. You may live forever if you go to Cancun and get some, you know, put in your IV. And so you really kind of have to take a step back and look at them. And so Johnny said, well, I'm going to describe them to you this way. First of all of this out there, they may or may not even be real stem cells. And stem cells, if you want to hear the real definition of them, is they're a cell that we have that is basically capable of turning into any cell. That's probably the simplest way I can put it. But the problem is they don't make their own decisions. And so I love Johnny's description to me for stem cells, because he said, you know, it's like putting 1,000 kids in a school playground and not giving them any rules and just stepping back and see what happens. And so we don't really know what they're going to do. And at least in this country right now, we can't grow them and we can't tell them what to do. We're learning with gene therapy and a bunch of other things how to tell them what to do. We're just not allowed to do that yet. Okay, so you have to be very careful when you say, well, I'm going to go to Cancun or Grand Cayman or Munich and I'm going to get, you know, stem cells put in my knee for 50 grand a trip or something like that. What are we really treating? Well, what we know they do when they're put in and not told what to do, they at least affect what are called the inflammatory pathways and things that cause pain. So there's a lot of good results from them that help inflammation and pain and those things, but we're not growing new stuff yet. Okay, and so I don't want anybody to be misled by that, because there's a whole new way to make a living in this world right now in the orthopedic standpoint, and that's doing these type of injections because they're not paid for by insurance. They're strictly cash pay, and you know, they're big businesses being built around some empty promises on them. And so I love new technology, I love new things, but I think we have to be careful what we're going to do. Okay, so that's sort of my spiel on stem cells. I hope before I quit practicing, we tell them what to do and fix a lot of the things we fix with surgeries and transplants and all that kind of stuff right now, growing new menisci instead of transplanting them, and healing partially torn ACLs instead of taking them out and making a new one. We're probably going to do that, at least while Gabby, you're still alive. We're going to probably be doing that. You know, I'm not sure while I am that we are. It's fun for me, too, because I got a lot of patients here that showed up, so it's been really fun, from all the way back when I was in Sugar Land to two of my patients who are getting married and just got engaged back there, and so, you know, and people from the Woodlands, like I said, so it's really fun doing this. So the next thing is PRP, okay? And does everybody know what PRP is? Okay, so PRP is called platelet-rich plasma, okay? And so what that is we draw blood, we spin it down, we take a platelet layer, and those platelets are some of our white blood cells that carry healing growth factors, all kinds of different ones. And so it's very easy to get. It's a little 5-minute procedure, and there are lots of applications for them also that are becoming very real. We still don't know enough about PRP. We don't know who has these growth factors, who has those growth factors. We're starting to figure those things out. But if there's anything that's coming in to mainstream medicine, PRPs are probably fixing to get approved by the FDA. They probably will start to get approved by the insurance companies, where they're not cash pay things for patients that want to be outside of the box a little bit and aggressive in healing things. We do know that for sure PRP is better than the lubricants you've heard about. So better than the lubricants for managing arthritis, okay? Managing, degenerative knees, degenerative shoulders, those kind of things. And they're a lot cheaper than the lubricants are also, believe it or not, and it's your own body. They affect inflammation just like stem cells do, okay? So they're pretty powerful in the anti-inflammatory world, and most of us are used to having steroids used in our aching joints for that, and that certainly makes it feel better, but it's not necessarily healthy, for the joint. So with the PRPs, I think we're moving in the right direction with PRP. But it's interesting. So men and women make different PRP, okay? You make different PRP in the morning than you do after a workout or do you do in the evening. We don't know what diet does to PRP, but it probably changes it significantly. Like the lunch I had today probably didn't do it any good for making PRP, but we'll talk about that later. If we're talking about health and fitness, I was a bad health and fitness day today, So, and the growth factors that are in PRP do different things, okay? So some cause scarring, okay? Cause abundant scarring. And so we don't want scarring in some places, like in a hamstring injury. We want it to heal, but not with a lot of scar that has the potential to re-injury or re-pull, if you call it that way. So now we've learned that we have to block one of the growth factors in PRP when we use them for hamstring injury, a medicine called losartan that has really changed our treatment, especially in the professional world of hamstring injury. So it has definitely changed the time off and the chance of recurrences. So we're finding places that the PRPs are better. And then sort of the last of the biologics that's out there is an in-between, okay? And so that's called bone marrow aspirate. And so that's where we take a bunch of your own bone marrow out of your pelvis. Sounds awful. It's a little bitty tiny needle. You probably wouldn't even know you had it done if there wasn't a Band-Aid there when you, anybody had bone marrow here? You had PRP, I think, didn't you? Yeah, and so that is basically it ought to be viewed as a more powerful PRP, okay? So the bone marrow we take out of the pelvis has a bunch of red cells, a bunch of white cells, but it has all the youngest cells. And when you're my age, you realize the younger cells are a lot better than the older cells, and so that's basically what you get with bone marrow is you get your youngest platelets. You do get some stem cells, but you don't get enough to fill up a playground, that's the problem with it, and we can't grow them and double them. So we do get some of that stem cell inflammatory effect. We do get, a lot of the PRP healing and inflammatory, but it's almost viewed as just a more, from my standpoint, trying to sort all this out and trying to help guide people in what to use and what not to use, It's basically a more powerful PRP to me. So, and the final thing about biologics is there is no such thing as a free lunch, okay? And so some of these things, bone marrow aspirate especially, used in situations where you're creating a lot of bleeding, some of those things like a ACL reconstruction where you're drilling tunnels in bone and all of that, can be part of a pretty significant scarring process that really limits motion, requires other surgeries. And so all of these sound so great when we talk about healing and better healing and less pain and all this stuff, but there's always two sides to things that you have used and you take and whatever in medicine. So it's always good to ask the questions of, hey, this sounds great, is there anything bad that can come from it? I guess the other new horizons, maybe you guys can tell me some if I think about it, but we're getting a lot better at transplanting and repairing and trying to keep structures normal. So if you look at focal wear areas on the end of the bone, 10 years ago the only thing we could do was do a microfracture, and that was sort of okay. I think you guys know a big linebacker defensive end on our team that came in first game, had a giant cartilage injury on the end of the bone, had a big microfracture with biocartilage, and then I didn't sleep for 9 months praying the guy was going to play again, and luckily he's showing up training camp again. But then we moved from microfracture into microfracture with cartilage things to pack the defects and control the fill, and then into transplanting bone and cartilage from a cadaveric donor that matched to the shape of the bone with living cartilage cells, because they don't have any blood supply. and they get their blood supply from the joint, and so we've talked about that, right? And so that has really changed the ability to heal localized areas of arthritis, but it hadn't changed our ability to heal the degenerative, worn-out osteoarthritic knee that the whole thing's gone. But maybe someday it will, and I know Kelly does a lot of total joints, but it's mine and David Abbasi's and Coop's job to put him out of business with all of our biologic treatment, and so it's always tongue-in-cheek, but I always say, yeah, total joint's kind of implantable cancer, and it's going to go someday, and so we need to grow some new stuff and replace it, and that is tongue-in-cheek because they're life-changing operations when you get to the point that you need them for sure. So, but we can transplant a lot of things, end of bones, cartilage on the end of bone, almost whole femurs right now, and half tibial plateaus and those things. That's too much doctor talk already for this, but we can transplant new menisci or cartilages, and they're very successful in this day and age, and being able to get those structures back to normal has made our ligament reconstructions a lot better. So that's the fun thing about sports medicine. Like all you guys that I know in here, you want to be active, you push. The great thing about sports medicine is everybody is very committed and wants to be perfect when it's all said and done. And the bad thing about sports medicine is everybody wants to be perfect when it's all said and done. And so that makes the job fun for me, and I think it makes it fun for those of us that are willing to stick it out with you guys to see it through, to the end either, because it's not always that easy for sure. And so that'll kind of end the spiel, because I think there's questions coming in, and I don't want to waste your guys' time if you have questions you want to ask. So you guys have any questions? Yeah, either one of you guys.
I'm a satisfied customer of a knee replacement by Dr. Blevins.
Awesome.
I was born club-footed, both feet. Had probably 10 plus operations before I was in the mid-teens. They don't even do operations on that anymore. Dr. Blevins informed me they use casts and
Right.
pieces. But I have a real kind of deformed ankle. So I'd like to know what's going on in terms of ankle replacements.
Well, they're real. You're a foot and ankle guy too, for sure. And correct me if I'm wrong. Bill McGarvey is our chief of foot and ankle at UT, and I think Bill's been part of development of some of the total ankle things. And so, like everything with ankle replacements, and obviously we're all individuals, and I tell my fellows all the time, not everything you see and do is going to be in the doctor book, because almost none of it is. You have to take patients individually and understand the big picture of what's going on. But ankle replacements for sure are real, and done in the right situation, I think they can be very functional and they can relieve pain. There's always the debate of would that ankle be better with a replacement or would it be better fused, And so I think you have to rely on the people who do a lot of that for the advice. But they are real, and in the right indications, I do think they work pretty well. Is that a fair? Yeah.
Okay,
You bet.
we have several questions that are coming in from online from ABC 13 and Greater Houston community. So I'd like to be able to address some of those as well, because this is being webcast as well live.
Great.
If those of you who have questions from the audience, just run them up to us and I will try and get them answered, or log on to abc13.com and you can put your question there under the health check.
Can I answer one more, because we had one here, and then we'll go to those.
You bet.
So I have a question. I had a MCL and PCL injury maybe 3 or 4 years ago. I play recreational basketball because I don't want to get old. Just like you said, I want to be perfect. But how much is PT and just flexibility after an injury, because I had surgery? Does that attribute at all to relief of pain? Do you see that?
For sure.
A lot.
For sure. In my world, I think, and I think a good question, because, getting well is a two-way street, and it's a commitment from your surgeon and the people at the hospital that takes care of you, and after that, it's a commitment of your surgeon and you, for sure, and it doesn't have to be the physical therapist, but a recovery program. And physical therapy plays a role for sure, but it plays a very early role for the most part. And you never get the perfect until you're back in the gym, you're being consistent, you're pushing and you're going. It's that conversation of going from good to great, you know, and the most important thing to get there is to regain all the range of motion, okay? Not close, all the range of motion. If you have a normal knee on the other side, to the other side. And if you get that, then the strength will come, then the function will come down the line. If you lose that range of motion, and if you even lose a few degrees of it, you're not going to check the perfect box. You know, so I think it is just as critical as having not only the right surgical procedure done, but the right one done well. I think that's really important to be able to get to those places.
And that's a perfect segue, because one of the questions that came through was in regard to physical therapy upon injury pre-surgically. So I come to see you because the back of my knee is killing me. You prescribe physical therapy. How helpful is that?
Well, you know, like I said, every patient's different, okay? But the trauma that comes from an injury definitely has to have a recovery associated with it, okay? And if you look at the example of tears of the ACL, which is about 99% of what I do all day, every day, if those people aren't ready to have surgery, the complications that can come after it can be really tough. And so the prehab or physical therapy ahead of time, but it's the same thing we talked about. It's getting that range of motion back to normal to start with. If you get it first, you'll get it afterwards. If you start off with a stiff knee, you can pretty much bet you're going to end up with a stiff knee. And so, yeah, I think it depends on the injury, but in most injuries, that allowing a recovery period and the ones that don't require emergent things done, the better you feel before you have them done, the more predictable your outcome is going to be.
Okay, well, I'm about to ask the question that may solve the divorce rate, or the oldest question in the world: ice, heat, or wet heat, or all of them, and if so, in what order and why?
For a cocktail or a hot toddy or what?
Shaken, not stirred, right?
Yeah, okay. I just wanted to make sure I was going down the right path. Well, you know, it's the age-old debate. After injury, for sure, ice, okay? And I think if anybody disagrees with me, you're wrong. No. You know, heat plays a role, but not in the acute injury setting. Okay, and so once you're through the first month or two, then I think heat, you know, especially on some other joints than the knee, in the shoulder, and some other places, can play a big role in making mobility exercises be more comfortable. So I think the right answer is there's a time and place for both.
Great. One of the questions that's just come through is, in the past 10 years, what is the greatest leap in sports medicine as far as advances? And second part to that is, and what hasn't gotten as much traction, just hasn't proven its mettle?
Well, you know, the last 10 years are not the golden years. I think, you know, 25, 30 years ago, late 80s, early 90s was the innovation and development of arthroscopy, and that totally changed our world. And so that is probably one of the bigger things that have happened that just had a major impact on our outcomes and our recoveries and our return. Weird to say.
When you say that, you mean minimally invasive,
right,
going with a scope.
Right, right, because almost everything we do in sports medicine right now is through a scope. Okay. We may have to make little incisions to harvest grafts and do other things, but almost all the work we do in the knee and shoulder is now done arthroscopically. And there's a few things that the old open ways are still better, but there are less and less of those as time goes on. The biologic things that really got launched about 10 years ago, I think are the most exciting things for us, because I believe for sure, and I think most guys that do what I do for a living believe, that they are eventually going to really change what we do. And they may put us out of business like we want to put Kelly out of business, you know, because a lot of the things we operate on, and we don't really have any other options to get people back to recovery places they want to be. I really do believe the stem cells, PRP, the biologic augmentation of healing will allow us to have our own tissues heal more than starting to replace things and rebuild things, which 20 years from now will probably be considered pretty barbaric for doing those things.
One of the questions that just came through again is quad sparing surgery, and can you explain that a bit, and why are more people not doing this, or more surgeons?
Well, so quad sparing is it's an approach to the knee for the total knee replacements for the most part, you know. And the quad muscle, that's the big thigh muscle. We throw out these things like it's, you know, everybody knows what we're talking about, but that's the big muscle on the front of your thigh, and that muscle is basically what controls your ability to walk, okay? And no matter what you do or what injury you have, that muscle is very reactive to pain and swelling and injury. So even the most minor injury can result in some pretty significant quadriceps strength loss, and that's part of the recovery you have to go through. So in the total joint replacements and some of our big cartilage replacements on the end of the bone, to spare the quad means instead, the old way is to make a big incision, split it up, pull everything apart, and sew it all back together at the end. And now it's more to stay out of the quad tendon and its attachment to the kneecap, and out of the quad muscle belly, and sort of go underneath it and lift it up and work underneath it. That's about as simple as I can explain it. But all of that are these new, less invasive approaches that are designed to spare function and start at a higher level of function. You know, because total knees now, Medicare wants them to be done as an outpatient, you know. And the old days, that could have never happened when the usual length of stay was 3 or 4 days, you know, 10 years ago. And so now a length of stay of 2 days, you're considered way outside the box. So the way you make people comfortable is muscle sparing procedures, new pain relief techniques, which there are some very exciting things. I can answer questions about that. You know, there is no pain medicine that's considered a good pain medicine right now, so we have to get out of that world too. So the quad sparing approach is smart. When you ask doctors why they don't do things, you're not going to get a bunch of good answers. A lot of times it's going to be, well, I'm doing it the way I was trained 25 years ago, and you certainly want your surgeon to do something he's comfortable with, but I think most of us want our surgeon to be a guy who's comfortable with doing the latest, best thing that can make whatever we're doing have the least impact on our patients too.
Great. How many cortisone shots can I get in my knee, hand, shoulder before someone cuts me off?
Well,
and is that total of the body, or is that per joint?
People that know me in this audience are laughing. So for me, 0. Okay? So I'm just being honest. That's not something that I think is in the mainstream of what we have at our disposal right now to treat those problems. And that's a little bit of a lie. There's an occasional thing you inject with steroids, but keeping them out of joints is a smart thing to do, I think. You know, there's no rule of thumb, okay? Steroid in your joint for arthritis, for inflammation, for all those things will make you feel better, and it will make your articular cartilage soften, wear out faster. So it's a double-edged sword. So I think, but you know, like I said, I have the most fun job in the world and the most fun group of patients in the world, because they're all very active and they all want to be very active until we find the fountain of youth and we can be active that much longer, okay? And so anything that can have a long-term detrimental effect in this day and age, I think there's other ways to approach it.
And that's another question that piggybacks on that a bit. When a patient comes in, when a weekend warrior comes in with a torn ACL, or less commonly a torn PCL, do you treat the average dad who's been out playing a game of horse, you know, with his friends differently? I don't mean treat them emotionally differently as you would a high-end athlete, but is the physiology different, and so your approach different from the way you treat someone who is staying in constant shape but also being torn down by their sport versus someone?
Well, I get asked that question a lot, and the bottom line is that the principles are the same, okay? The people are different, okay? And so, you hate to admit that there are people with better genetics than you, but there are people with better genetics than me, okay? I mean, there are guys that make recoveries just look unbelievably easy, and there are people who look like they were going to make recoveries unbelievably easy that struggle mightily to get over things. And so I go back to it, it's all about the person you're taking care of. It's not a broad, you can't say anything about this that you can apply to everybody for the most part is kind of how I think. What the professionals have that we don't is it is their job to get well, okay? Our problem is we all have a bunch of other jobs we have to do, and we have to have time to get well outside of those other jobs and life things that we have to do. But if you tear your ACL and you play for the Houston Texans, you are going to be in that training room for 8 hours a day, 6 days a week until you're back on the field. You're not going to be allowed to go home to wherever you live in an off season. Your job is to get well, and that's the way these guys come back to such a high level of play in a very short period of time. They don't get well any faster, they just get a lot better faster than everybody else does, because they have the attention of 2 or 3 very high-end physical therapists, all the latest, greatest technology and treatment things that no one else has because you can't get them paid for. And so the real difference is that their genetics are different, I think, in a lot of them, and they have access to great care 24/7,
POPs, clicks, crepitus, joint mice without pain.
Call it noise and ignore it. She said
the question,
joints that pop and click and do all that and they don't hurt, then I say call it noise or give it a name and ignore it. Yeah.
For people what is the best age to receive a joint replacement? From a
225. Isn't that right?
Is there a cutoff age?
Well, I think Kelly would attest to this too. Joint replacements are great operations. If you're looking at the knee, if you're looking at the hip, if you're looking at the shoulder, as long as it's the right time to do it. Okay, and if you have, we'll just use a knee for example, because that's the only joint I can spell. If you have a knee that is arthritic and it affects your life every day, and it hurts every day, and it is interfering with your ability to be who you want to be or do what you want to be, then it's time to get a joint replacement. And I don't care if you're 40 or 60 or wherever, because if you get 20 years of function out of it, well, hell yes. I mean, if it has to be redone, then you redo it again. I think the technology and the implants that are designed right now are all great, and their longevity is getting further and further out. But the biggest mistake people make, I think, in joint replacement is having big surgeries done for little things that they don't really need, that don't really affect their daily life. And when you do a joint replacement in that setting, you're going to probably really regret how you feel after it. And so, I think if pain drives you to that and it affects you daily, then that's the time, regardless of your age, to start thinking about it.
What type of sports injuries require immobilization versus retraining or strengthening other muscle groups?
You're asking the wrong guy that again, probably. And so, there are very few sports injuries that require significant periods of immobilization. Maybe a complete tear of your quad tendon, a complete tear of your patellar tendon. For me, a very short time period, like a week or 10 days to allow some early healing. That's probably the longest I would ever immobilize anybody. I think even in the fracture world these days, anywhere, there's not many things we treat with immobilization.
Okay.
We got a question back here at the back.
Oh, I'm sorry, sir. Can you be seated while you're asking your question? I believe there's a camera in the way. Okay. Now yell.
I've had arthroscopy in both knees, and my right knee is bone on bone, but it's been that way for years. And I've had Synvisc every 6 months. Is that what you mean by lupus?
Yeah.
Okay. So,
Well, I would never change from anything that's working. That's for sure, you know. And so I think there's something else out there. If it doesn't, keep working. But, you know, if your mobility's there, your pain's good, then it doesn't matter if you're bone on bone. I have a great story to tell that I tell the residents and fellows all the time. So I was in training, I was up in Dallas, and we were at a total joint conference, and our big total joint guy, who's dead now, rest his soul, put up an x-ray of both knees. And one knee was bow-legged and bone on bone and just looked terrible, and the other knee looked totally normal. And he looked at one of my resident buddies. Thank God he didn't look at me. He goes, "Well, what do you want to do for his knee?" And he said, "Well, you know, Dr. Mooney, that's a varus knee. It's bone on bone. It needs a total knee." He goes, "No, I wasn't talking about that one. That knee feels fine. What do you want to do for his other one?" Okay, and to some degree that's kind of true. Okay, and so that's another good point about joint replacement. I think just because your x-ray looks bad, it's not a reason to have a knee replacement. Okay, it needs to feel bad too. Okay, and so, but I'd tell you, if Symvisc is working, I would stick with it till it doesn't work, you know. And
Another question. I've heard that about 20% of knee replacements lead to further complaints and maybe need some sort of correction.
well, so how's the right way to say this? I think that's probably true, pretty close. And so I think everybody tries hard, or most everybody tries hard. I don't think there's a lot of doctor criminals out there. There's probably a few. But I think when you have operations that have that much, that can have that much effect on your life as a whole, you should be at a place where that's all those guys or girls do. Okay? And if you're in the hands of somebody who does 10 or 12 total knees a week, your likelihood of ending up in that 20% that have all sort of things go wrong is pretty low. Okay? If you're in one of the offices that they do 1 a week or 2 a month or 3 a month, then I think the likelihood of having complications from that operation is going to go way up. If you look at what I do, ACL reconstructions, 80% of the ACL reconstructions in this country are done by orthopedic surgeons who do 10 or less a year. Okay? I do about 400. Okay? And so it's not that they're not good, it's just they don't get the experience and they don't understand the things that can lead to the complications, and when they have one, they generally don't know what to do with them. And I always tell our learners and stuff that you don't define yourself as a surgeon by how good you are in surgery and your results in the recovery room. You define yourself by how you take care of your problems. Okay? And so that's never more true than in total knee replacements, I think.
Okay, this is the last, we're going to have to probably
You can
cut
tell I have a
these off.
soapbox, so you don't want to get me up on it, you know.
And just for those who are listening in the audience and in the webosphere, I suppose we call it, out in ABC 13 land, we will be answering your questions over the next couple of hours and tomorrow. But this is the last overarching question.
Okay.
When it comes to repetitive use or overuse injuries, is it better to lay off a bit or just plow through the pain? And the second part of that question is, what would you determine as the greatest overall exercise for your overall body that a person should be doing?
Oh, those aren't fair questions, either one of them, yeah. First one's easy. If you truly have an overuse injury, there's a reason you have it, overuse, okay? And so if you think plowing through it makes sense, that's just crazy, okay? So that one's easy. You know, I don't think there's any one perfect exercise, okay? It depends on the joint, it depends on the problem, it depends on, you know, your level of health overall. If you said, is your cardiovascular health and those exercises more important than your bone and joint health? Well, the cardiologist would say yes, we would say no, you know, because it depends on what you're trying to get to and what you do. So rather than saying, is there one exercise, if you want to look at fitness, you want to look at cardiovascular health, it's running. I mean, it's running on the treadmill, and I think it's pretty clear that gets those results faster than anything else, but it has its downsides that go with it probably. But there's a constellation of exercises that are best for individual joints, individual problems, you know, individual different injuries, all of those kind of things. And so I don't think you can say, well,
Physical therapist working with your
your
orthopedist.
orthopedic surgeon, your PA, your physical therapist, your athletic trainer, your strength and conditioning coach, your Pilates teacher, any of those, that should be a part of how they address all the things you're seeing those people for.
Okay. Thank you very
bet.
much.
Thanks.
And Dr. Lowe, thank you so much for just sharing your time and your expertise.
And you're giving me that white matte Mercedes back there, that beautiful one back there in the back.
And the keychain you can wear around your neck.
Awesome. No.
But the Houston Texans are clearly in very good hands, and if we fans don't pull a hamstring or blow out our ACL just trying to get our seats this season, we should have a very good season. And thank you to Mercedes-Benz of the Woodlands for hosting our second and very compelling event. And certainly a huge thank you goes to ABC 13 for giving us a platform to arm our Houston community with knowledge and awareness regarding our health. I'd also like to thank UT physicians, our partners in health, our clinical faculty from McGovern Medical School at UTHealth, who teach and train and treat and provide the highest quality care for your entire family. Some of our UT physicians and staff are with us tonight to provide more information, so please mill around and find someone that looks, intelligent and knows what they're talking about, and feel free to bend their ear and ask them questions. Or please visit uthphysicians.com if you have any interest in making appointments. Tonight was the second of 7 UT Health House calls. Our next one will cover pediatrics with a particular focus on back-to-school health and the healthy habits that promote academic success. It'll take place Thursday, August 16th at 6:30 at Mercedes-Benz of Houston North. For more information about UT Health House calls, please visit the Health Check section on abc13.com. Thank you, Dr. Lowe, and thank you everyone for coming, and we hope to see you next time.
Thanks.